We are presenting today the physical exam, what matters and why. My name is Devesh Vashishtha. I'm a third year family medicine resident here at Swedish Cherry Hill in Seattle. And my partner is Dr. Alex Kivimaki, who is also a third year resident. Alex can't be with us today. He sends his regards and is recovering from an illness. And with his permission, he wants to tell everyone he's getting better and he's with us here in spirit. Um, and let's go ahead and get started with what I hope is going to be an interesting topic. So why did we pick the physical exam? The first reason is the physical exam is awe-inspiring. It is one of the things I think that drew a lot of us to medicine, the opportunity to be able to just see another human or examine another human and be able to come to a diagnosis that might help serve them. There's something really, I think, special and really, I think there's a level of human connection about it that is really awe-inspiring. In the current context, a lot of us have been missing in-person interactions with patients. And this is true both in the clinic setting, where we're doing a lot more telemedicine, and in the inpatient setting, we used to do what are called bedside rounds, where we would be seeing patients, examining them as a group and learning. And a lot of that has stopped because of the COVID-19 pandemic. And finally, I think a lot of us, all of us really are interested in providing efficient care. We all want to know, how do we serve our patients while maximizing our resources, and the physical exam remains one of our, if not our lowest diagnostic tool, lowest cost diagnostic tool. There is some excellent existing literature on evidence-based physical exams, and I will be pulling from some of this literature as we go through this talk. One of these is JAMA's Rational Clinical Examination, which is a really awesome series that looks over a lot of the data behind the physical exams that we do and how useful they are. There's also this book, and it's my understanding from people who are more experienced than myself and Alex, that when this book came out, it was revolutionary, Evidence-Based Physical Diagnosis by Stephen McGee. And that this was one of the first times that the physical exam was presented as something that can be data-driven and really optimized for the patient's benefit. And so one of the arguments that we'll be making today is that of all times, this is a particularly good time to rethink how we approach the physical exam. And I'll explain why. For one thing, healthcare costs, as we all know, are rising at an unsustainable rate. So healthcare makes up about 17, 18% of GDP, and that percentage is projected to continue to go up in coming years. And so we really need to think of what are low-cost ways of reimagining our healthcare system. And I'll say this is based on personal experience, and I think with just discussions with a lot of our colleagues, is that we often don't know the evidence behind our physical exam maneuvers. We're taught things like, JVD is for heart failure, or, reproducible chest pain, which we're actually going to talk about today, can help you move away from cardiac chest pain. But we often don't know the numbers and how much we can actually trust in those exam findings. Another reason why the physical exam is sort of a timely topic is that starting in January 20 of this coming year, there are going to be new rules from the Centers for Medicare and Medicaid Services that are actually going to remove the history of physical exam from billing components. And this is specifically for outpatient E&M visits. So the 212s, 213s, 214s, or the new patient encounters. And so what this will mean is that we only have to document the relevant physical exam and the relevant history. And so, we are going to start only documenting the relevant exam. And so then it becomes that much more important that what we do is relevant, is evidence-based, is useful. Another reason this current moment is important is that we are having new technologies such as ultrasound that augment and replace portions of the exam. And finally, with the pandemic and this sort of acceleration of telemedicine, the exam is changing as we speak. So in this sort of current moment, as we're rethinking our approach to the physical exam because of all of these various external factors, we'd like to present that this approach should be the following. It should be patient-centered. It should be evidence-based and focused, and that part two will make up really the bulk of this presentation. It should be able to integrate telemedicine, and it should be practice changing. There should be things that we can think about that change how we learn, how we teach. And so these are the objectives for the talk. In terms of being patient-centered, we'd like to review evidence around the experiential aspect of the physical exam, specifically for the patient. Talk about how the physical exam can be evidence-based and focused, and those two components really draw one from the other. If we know the evidence behind what we do, we can really focus a physical exam that is relevant for the diseases that we're trying to detect or the conditions that we're trying to diagnose. Able to integrate telemedicine, and finally practice changing, really envisioning how our education and health systems might better integrate the physical exam. So getting started with objective number one, let's review some of the evidence behind the experiential aspect of the physical exam for the patient and physician, but more so for the patient specifically. So this is Junko Ida, who is actually an anthropologist based in Japan, who's done some research and specifically looking at the experience of the physical exam. And so this is a quote from a literature review, which is that medical articles seem to positively value physical examination in terms of the physician-patient relationship, while social scientific work really focuses on the negative aspects of physical examination. And we found this very interesting. So if you look at sort of the medical literature, so to speak, what it'll say is that close proximity and touch strengthen doctor-patient relationships, reduce patient anxiety, can have a healing effect. If you look at social science, which is being broadly characterized as sort of a different discipline, patients would find this proximity sort of invasive. There's also interesting data that shows in non-Western societies, the exam is considered to be an essential component of a good encounter with the physician, that in some non-Western cultures, there's data that shows that examining someone actually makes them feel like you made more of a connection. There's also another review that's been done, which reviewed thousands of visits across kind of a systematic review, and found that there were numerous behaviors that were associated with positive outcomes. And one of the most important of these at the bottom here is that orientation about the nature and findings of examination create high satisfaction levels. And so this has been referred to, I think, sometimes as signposting when we learn it in med school, but being really clear with our patients. Is it okay if I examine your heart now? And then saying, when I listened to your heart, I didn't hear anything concerning. That can be really one of the key factors that drives patient satisfaction. So moving on to what I think will be kind of the bulk of this presentation, the physical exam really should be evidence-based and focused. And I think this is going to be kind of fun. So I'm looking forward to seeing what you all think. I hope you all have your coffee and are trying not to drive too much and listen to this at the same time. Keep your eyes on the road. So to understand evidence behind physical exam maneuvers, we have to apply pretest probability and likelihood ratios. And so raise your hand if you remember what those are or have any recollection of those words from your first or second year stats courses from med school. Actually, we think these are super important. So pretest probability can be sort of generally described as what is your level of suspicion that the condition exists. And I'll give you an example here. So let's say a patient comes into your clinic with a knee injury and their knee is swollen and it's clicking. You might, in your head, say this person has a pretest probability. So before I do any further diagnostic tests, of 60%. I think this patient has a 60% chance of having a meniscal tear. So that's the pretest probability. And the second thing that we use as we're thinking through and doing an exam is the likelihood ratio. And specifically, the LR, the likelihood ratio, tells us the changes in odds after a test. And there are two ways to describe it. There's the LR positive, which is how much the odds of having a diagnosis change after a positive test. And then there's the LR negative, which is how much the odds of having a diagnosis change after a negative test. So for the previous example, for the patient with some knee clicking and pain, the positive likelihood ratio, or the LR positive for the McMurray's, which is one of our tests for diagnosing a meniscal injury, is 3.4. And then the cool thing is you then take your pre-test probability and your likelihood ratio and you essentially combine them. And there's some fancy math that goes on where you're converting between probabilities and odds. But the nice thing is eventually you can come to a probability of a diagnosis. So in the knee pain case, a positive McMurray's shifts the probability of a meniscal tear from 60 to 84%. So your pre-test probability after the exam, the probability actually goes up quite significantly. And so this is sort of the framework we'll be using to think about some of the physical exam things we do. And I did want to present that it's important to know kind of what likelihood ratio is useful. And so a lot of the literature will say essentially for the positive likelihood ratios, you're trying to look somewhere between 5 and 10. That's pretty good. Obviously greater than 10 is excellent. And then negative likelihood ratio, kind of less than 0.2 is considered useful. Obviously this depends a lot on your pretest probability. So let's jump right into an example that I think will help demonstrate why we might find using likelihood ratios in particular to be useful for our clinical practice and for learning. So this is an example of a patient who could be someone that we're seeing on our ER rotation. So a 72-year-old patient with AFib, diabetes with an A1C of 13, recurrent multi-drug resistant UTIs who's brought in by ambulance from an assisted living facility. The patient is obtunded and has an initial blood pressure of 70/40. And so I pose two questions to you. First of all, is this patient sick? And take a minute, absorb that data, and you can just make a decision, yes or no. And is this patient likely to be admitted? And this is the sort of questioning that's going on all the time, whether we're seeing someone in the clinic, whether we're seeing someone in the ER for the first time. These are the processes that we go through in our heads. It's a lot of triaging. So the question I think that this example poses that's really interesting is how good are we at determining sick versus not sick? We don't plug this patient's vitals into some sort of algorithm. We just kind of think about it. And so they've actually studied this. They've done a prospective observational study of resident and attending ED doctors with 266 observations. And essentially what they did is they gave really basic info, like a short vital sheet and a short sort of triage note to the physician. And the physician had a chance to eyeball the patient, do like a 10-second assessment. And they essentially made two assessments. They said, will this patient be discharged or be admitted? And second, is this patient sick or not sick? And sick was defined as having a life or limb threatening criteria. And the results, I think, are really interesting. So if you look at patient disposition, so discharge versus admission, it turns out that the thing that was really significant that had a likelihood ratio negative of 0.19 is that physicians were pretty good at saying when they say this patient is not going to be admitted, that they're probably not going to be admitted. And the sick versus not sick part, this is the one that I think has a really significant likelihood ratio. And remember, we said 5 to 10 for the LR positive is considered pretty good. So we're pretty good at, if we say that someone is sick, the odds that person is sick go up by about 5.7 times. And I think this has implications, right? And I'll explain this. So if you go back to this case, I want you to think, what was your initial sort of gut response? Did you think this patient was sick? And did you think they were likely to be admitted? And I think a lot of us would have said yes and yes. And I think this is important because the data, that study actually showed that residents, if they were analyzed separately, also tended to get this right. And so this might be a reason for us to start trusting our gut instincts even more. you're on a busy clinic day and you're seeing a lot of people, and your preceptor barely has 30 seconds to help you out. But if you've made an initial impression that someone is sick, that's probably something you can trust and rely upon. So let's go now to another example that pulls us away briefly from likelihood ratios that I think is just an important part of the physical exam. So you have a 45-year-old patient with a non-significant past medical history who comes to your clinic, is roomed in 2 minutes, really efficient rooming process, and has a blood pressure of 156/95 with no real symptoms. So how can we eventually determine if this patient has hypertension? So as we all know, the in-home 24-hour ambulatory readings or multiple home-based readings are the gold standard for blood pressure monitoring. These can be kind of hard to actually get in real practice. And so we have what are called automated office blood pressure. So these are the cuffs that you attach in the office, and not manual readings, but automated, and they have a built-in delay. So essentially what happens with these, and I think these are the standard of practice in a lot of places in Canada, but not so much in the US yet, is that the MA or whoever is placing the cuff actually leaves the room and sets the cuff to start, and it records a series of consecutive readings. So there's timers in these machines that can be every 2 minutes or they can be every 1 minute. And if it's every 1 minute, it only takes about 5 minutes total to get 5 consecutive readings. And the point is that there's no clinical personnel inside the room with the patient when this automated office blood pressure is being run. And there's a lot of data actually that shows that automated office blood pressure is comparable to ambulatory readings. So if you're trying to get a proxy for what it would be like to get a home blood pressure, we probably should be using this automated office blood pressure. And so this is an example of the machine, and I think we're all going to raise our eyes at the cost of it. This is one of the machines that was cited in this study, the Omron 907. Presumably there are lower cost versions available. And so if this patient were to come in, one argument might be, look, ideally we try for ambulatory readings, but if we can't, we should have automated office blood pressure in our clinics, and we should be using them per protocol if we're trying to really capture what the ambulatory reading would look like. Okay, so now let's jump back to our third example, which is going to be taking us back into the world of pretest probabilities and likelihood ratios. So you have a 35-year-old male who has non-significant past medical history and comes into your office with acute onset, mild chest pain without associated symptoms. And his chest pain is reproducible in clinic. You estimate his pretest probability of having ACS at 0.05 or about 5%. You're not super suspicious. So the question becomes, should you initiate cardiac workup? So this has also been studied. They've done a prospective double-blinded trial of ER patients at one hospital who were seen for acute chest pain. And they actually found that reproducible chest wall tenderness, and specifically where you take one finger and place it right over the part where the patient points to. And the patient actually in this study is sitting at 30 degrees elevated, and one index finger is used. Wow, I push on myself and I'm creating chest pain. Something's going on there. If you push on a specific location with your finger, and the patient should feel like that pushing is creating pain in the exact same quality and intensity that their initial complaint pain was. And this actually rules out ACS with a likelihood ratio negative of 0.15, which is less than our threshold of 0.2 and is pretty good. So coming back to this case, we can now do that fancy math that I was talking about that I won't go through. But if you use your previous pretest probability and you use this pretty low likelihood ratio, this patient's probability of having an acute coronary syndrome based on EKG or TROP is 0.7%. It's pretty low. And so you may not send this patient in for cardiac rule out. This is going to be the fourth. I think we have one more example now of these likelihood ratios. So the importance of likelihood ratio positive, I think, is demonstrated really nicely in this case. And so the example here is a 34-year-old female who is 8 weeks postpartum. who comes in with sharp pain over the radial styloid. And you're trying to figure out what's going on. You know, this patient is probably, or in this case, let's say this patient is breastfeeding, and there's a lot of motion that's happening at the wrist, both lifting the infant and feeding and all of that. And so they've actually studied some of these tests for pain over the radial styloid. So there's then a prospective study of 100 patients with spontaneous pain over the radial styloid. And everyone, I think, knows or has heard of Finkelstein's. They compared Finkelstein's test, which actually is a misnomer, and I'm not going to get too much into that because it gets confusing, but they compared Finkelstein's test to a new test, which is called wrist hyperflexion and abduction of the thumb. This test is abbreviated WHAT, which I just thought was kind of funny. And then they used X-ray and ultrasound as the gold standard to sort of make the diagnosis. And this is specifically for diagnosis of Dequervain's tenosynovitis. So this, as you will all remember, is sort of what the Finkelstein's test or maneuver looks like. And this is the WHAT test, the wrist hyperflexion and abduction of the thumb. So the patient essentially hyperflexes the wrist and then moves the thumb outwards, so abducting it, and it's against resistance. And if pain is felt against resistance, then that's considered positive. And so they've actually shown that the Finkelstein's test has a likelihood ratio positive, and that's kind of what we're using it for. We're trying to use it usually to diagnose Dequervain's. It's not statistically significant, so the likelihood ratio is 1.04. The WHAT test is actually a little bit better. It has a higher likelihood ratio. It's also not that good. And so I think what this shows is that we don't really have great diagnostic tests for Dequervain's, even though we do tend to use some of these maneuvers pretty frequently. And if we were to step back and say, look, we can't necessarily diagnose Dequervain's easily with a physical exam. Ultrasound, and if you can see things on the tendon and whatnot, that's different. If you have that skill, that's great. But if you can't make a definitive diagnosis of Dequervain's based on your exam, then it's important to sort of step back and say, what else could be causing this pain over the radial styloid? There are a lot of things that are non-traumatic, things like OA, something called intersection syndrome, ganglia, radial sensory nerve entrapment in the forearm, calcific arthritis. So the list is long. And so when this patient comes to you and you're hearing this story, it might be more that Dequervain's is perhaps a diagnosis of exclusion, where you have a history that points you there, and you make sure that you're not missing things like trauma, arthritis, intersection syndrome. And then if you can use ultrasound to diagnose, that's great. And if you can't, at least you've ruled out the things that could have slightly different management. And then you can move down the pathway of, bracing and NSAIDs and activity modification, all the things we use to treat Dequervain's. All right, it's our last example. Hope you're holding with me. Can pour that second cup of coffee or whatever you need to stay awake. So this example is a 22-year-old soccer player who comes to your clinic 6 months after an acute injury in which his right knee was directly impacted by another player from the lateral aspect. At that time, his knee was acutely swollen and eventually got better after several weeks. By the way, this case, this literally happened to me in clinic with Mike Erickson. This was like 3 days ago, so super timely. He now has intermittent medial and anterior knee pain, and he feels like his knee might give out. So you're hearing the story and you're like, knee giving out, soccer player, lateral injury, pretest probability of an ACL tear is 50%, pretty high. So what is the one test that's going to help you decide if you need an MRI? And so they've done pretty awesome studies. There's a meta-analysis of 17 studies that evaluated the Lockman compared to the pivot shift and anterior drawer with gold standard of MRI. And essentially, the Lockman's test is really good for this. So it has a likelihood ratio positive 10.2. There actually are some studies that show it can be as high as 20 or 30, depending on the study, but it's really good. And that's just, laxity at that knee joint with anterior stress, with the hamstring sort of taken out of commission. So that's the Lockman test. And so if you were to have this patient and you performed a Lockman's, and let's say it was positive, then your pretest probability actually increases from 50%. After Lachman's, the odds of an ACL tear are super high, 91%. And so you would go straight to an MRI. And so knowing which of your tests has really high likelihood ratios can be pretty powerful in determining the need for further diagnostic imaging. And so now we'd like to move over to the third objective of this talk. And this is really going to be a brief overview of telemedicine, reviewing some of the evidence. So telemedicine in general, there's data, the data is just lacking. And I'm really only going to share a couple of studies here. So they've, for example, have studied telemedicine histories and exams to diagnose dementia. And so this was performed by geriatric trained physicians who actually had 100% agreement between telemedicine and clinical diagnoses. So if a doctor was evaluating someone over a video camera, and then another doctor was evaluating them in person, there would be 100% concordance there. So there are probably some things that telemedicine is really good for and useful for. They've also studied pharyngitis to see what is the agreement between telemedicine-based and in-person exams for throat complaints. And it turns out that the data sort of vary. There's some things that you can see well, there are other things you can't, but really what we can see is that for pharyngitis, the video exam is just not super useful. And I'm not really going to go much more in detail on that. I think our general understanding from the literature is that there's a lot of work to be done in understanding telemedicine. There are a lot of things we're doing now over the phone or over video that we didn't used to do before. Having patients, check for rebound tenderness on themselves, or tell us where their maximal point of pain is over the phone. And that just means there's a lot of research that still needs to be done on this. So finally, I'd like to spend just a few minutes talking about how, this understanding of the physical exam might change our educational and health systems so that we can better integrate evidence and maybe some new technologies as well. So we'll call this relearning the physical exam. If you think about your pretest probability, this is an argument to really take an amazing history, right? So when someone comes in with an undifferentiated concern, let's say they have a cough or they have chest pain or they have abdominal pain or whatever it is, you're really going to be entertaining multiple different diagnoses at the same time. And you're going to be in your head, we don't always think about it this way, but we are sort of creating individual pre-test probabilities for each of our most likely diagnoses. And so if we can become really great history takers, we can maximize our ability to get a pre-test probability that's going to give us the most information. To the extent possible, and this is something that I felt was and still to some extent is lacking in my own learning of this, is that we should be teaching likelihood ratio positives and likelihood ratio negatives for our most common maneuvers. We should know sort of, if I perform this test, is it actually useful to the patient to making a decision about imaging? And if it's not, then maybe we shouldn't be using some of those maneuvers. The other thing is that practice actually makes us much better at our likelihood ratio positive and negative for a given exam maneuver. And so there's this really cool example of a study which examined cardiologists compared to ER doctors. And what they did is they had the doctors listen to the heart and see if they heard a murmur, and they diagnosed that murmur, it was a systolic murmur, as being clinically significant. And then the patient got an echo. How likely was it that it was a significant murmur? So that it was moderate to severe aortic stenosis, that the patient had a significant shunt or intraventricular pressure gradient that was substantial. And it turns out that cardiologists were actually like better at this. Their likelihood ratio was like 30 or 40 compared to like 10 to 20 for ER doctors. And so I think what this demonstrates is that if we can keep practicing our physical exam, we can get way better at this and improve our ability to diagnose. It might mean doing things like, if your patient has a finding on ultrasound or imaging, then practicing and with their permission, can you determine what the clinical correlates are of that finding and get really good at that? And then of course there's room to conduct more research into telemedicine-based exams. And finally, just thinking briefly about health systems, how they might change with this sort of new understanding of the exam. I mean, for one thing, we should all be doing automated office blood pressure, taking the correct number of times with appropriate intervals. If you think about it practically, if it only takes 5 minutes to get good automated blood pressure readings, and you can get a much more accurate diagnosis, it's less likely to be falsely elevated. That can save time in later in the visit in counseling patients on ambulatory readings. It can save time in overdiagnosis of hypertension. And so I think that if we spend a little extra time on this automated blood pressure, we can actually see a lot of benefits both for the patient and for clinic workflows as well. And then finally, this is something that is more of a brainstorming point, but what are clinical decision-making tools that apply to vitals and physical exam? And we may not know what this looks like, but you know how in Epic you get these pop-ups now for trying to order a CT scan when a KUB would do the same, and there's a warning. Well, why don't we have sort of decision aids that are useful for the vitals or physical exam? And this may be more of a hindrance, but it's at least something to think about. So I wanted to just share again all the resources that we had used for this talk. JAMA has this awesome thing. So if you just search in Google pretest probabilities and likelihood ratios for clinical findings, you can find a huge table that actually goes through all the likelihood ratios for different tests and shows you the original data sources. And then also just to throw out to Stephen McKee's book, Evidence-Based Physical Diagnosis, which you can get on Kindle, you can order it online if you really want to sort of nerd out about all of these exam maneuvers. We wanted to just take a moment to acknowledge our amazing faculty, Barry for helping give feedback on these slides, and Shannon also for her amazing feedback on the slides in the presentation. And then these are the sources we use, which we'll make available to everyone. And that is all that I've got. So would love to give you a moment to think of some questions and see what we can discuss here. And while folks are thinking of questions, I was also going to share that there is actually data around the use of an annual preventive exam. And essentially that visit, there's some data that shows that examining someone and getting lab workup when they don't have a concern about something can actually lead to more diagnoses and fewer, it doesn't actually improve morbidity and mortality. That was kind of an interesting point. But insurance still pays for an annual preventive physical, which is really interesting. So my brother is on this talk. Thanks, Gopal. Can you walk us through the math for an LR positive calculation? I probably could. It has to do with sensitivity and specificity, and it's going to be like 1 minus one of those over one of them. And I think it's probably easier just to Google, but I can tell you what you need for it. So essentially what you need is you need a 2x2 table, and that's pretty much it. So once you have a 2x2 table of, patients either, had the outcome of whether they truly had X or Y, and then on the Y-axis you have what their physical exam finding was, if it was positive or negative. And so once you have that 2x2, you can derive it. But I would say probably Googling it is going to be faster than me trying to find the formula right now. Okay, we have another question here from Kristen. Thank you. Apologies if I missed. Was pretest probability increased if the patient was postpartum? I tend to diagnose it from the doorway if it's a parent with an 8-month-old, since that is point of maximum Chubb to minimum mobility ratio. Okay, I like that. So there actually has been, and I'm not an expert in Dequervains by any means, and I would agree, I think that when someone is postpartum, like my suspicion is like way higher, my pre-test probability. There was a nice case report actually that I came across and I want to say it was in the Journal of the American Board of Family Medicine. And what they found was they actually presented a case study where they looked at does a patient who was postpartum, who was having prominent radial styloid pain and was kept getting treatments actually for Dequervains. And it turned out that this patient actually in reality had something called intersection syndrome, which I won't be able to describe all the pathophys of, but it's pain that's a little higher up on the wrist and is related to some of the compartments in there. And the treatments are actually a little bit different for that. Sometimes you can actually just inject saline into there. And so that's eventually what happened to this patient is they kept having pain, several months postpartum, got an ultrasound diagnosis of intersection syndrome, got that thing injected at a sports medicine clinic, and actually did a lot better. And so I think that probably there is room to consider those alternate diagnoses just so we can be, super accurate. Are you concerned about bias in using your gut to make decisions, e.g. missing women who are having heart attacks? Wonderful point. Thank you, Ashley, for that. I think the short answer is yes, for sure. There is going to be a huge amount of bias. And I guess the question would be, how do we change our biases, especially in creating, probably bias is going to play a role both in your pretest probability, because you're going to see someone and have potentially assumptions about them based on how they look. And then the exam too could be influenced by that if we have an unconscious bias towards a person based on, gender, whatever, sexual orientation, race, ethnicity, etc. And so I think I would imagine the answer to your question is yes. And I think that what we have to do is just work really hard to overcome those biases. It may be that we need to use these, that we need to have teaching on how bias affects pretest probability, and that, for certain, actually give very specific examples. Like if a woman is having chest pain, we should actually maybe take that more seriously, or be aware to look for other symptoms that are so-called atypical. Even that term atypical, I think, is kind of sexist, but looking for things like nausea and discomfort and things that are more subtle, essentially. So thank you for that question. Dr. Hoffbauer says, thank you, appreciate it. Jeremiah Bernhardt, did you find anything that helps to determine pretest probability based on the HPI? The short answer is no. And I wonder, maybe the question you're getting at is like, if you use the full old carts, like mnemonic, like do you have more information and more data versus if you just did like onset? I don't know. And I think that's a great question. It's something that we should be studying and looking into. Rich Kovar, thank you, says, great job. Can you comment on the Murphy sign in terms of pretest probability and specificity? No, I can't, because I don't know, but I can point you to the JAMA Rational Clinical Examination likelihood ratios, which you can Google. And that maybe you can teach me when we're on inpatient together next. Dr. Teraday says, oh, here we go. Shannon answers the question. Appreciate it. So for Murphy's, studies of this sign in patients with pain in the right upper quadrant reveal a much better diagnostic accuracy than conventional palpation. Okay. And so this is a sign for gallbladder pathology, right? I'm assuming specifically for choledocholithiasis. And so it has a likelihood ratio positive of 9.9, which is actually pretty great. And they describe this as having superior precision. Okay, anyway, someone who's more experienced can probably talk about this, but okay, Dr. Teraday says, from all your reading, what are some additional ways that your physical exam will change? I think other things that I just came across, like really quick pearls that I learned. So I would try to get our clinic to use automated office blood pressure readings. I'm going to start really carefully making sure we're checking temporal artery temperatures for kids, which I think we do anyway, but there's been data that shows that temporal artery temperatures correlate much better than oral and ear temperatures with rectal temperatures, which are the gold standard. So temporal artery is the best. And I think I'm just gonna probably keep learning. I think MSK is the area in which I find these are most useful. I wonder if we could maybe even have a didactic session later where we just talk about likelihood ratios for like common musculoskeletal tests. I think a lot of us find the MSK exam kind of overwhelming because there's so much anatomy and there's just so, it seems like there's so much knowledge. And, you know, I would be pursuing, at least for myself, like a understanding of the 10 or 15 highest yield musculoskeletal exam techniques that can help me decide, you know, imaging and ruling things out. So Dr. Jones, thank you, Rob, for being here. Do you know, and actually you're not a student anymore, sorry. Do you know if there is capability for EMRs to have such likelihood ratio calculators built in, i.e. are the data conducive to the EMR interface and real-time workflow? The short answer is, I think no, and I wish it was the case. So I actually recently had a case of a pediatric patient, and this is talking about vitals, which I feel is part of the physical exam too, who had a head circumference. So this was like a 9-month-old who had a head circumference that was continuously increasing. So you have your 99th percentile, and this kid was essentially starting to go off the curve. And we were using our sort of well bias, and the kid was developing normally and trying to say, oh, like, this kid will be okay. Let's keep a close eye. Let's watch development. It turned out eventually that this child returned at 12 months or 15 months and had some developmental delays, got an MRI and had a metastatic pineal gland tumor, and has now had sort of surgery and chemo and everything. And I keep wondering, you know, you go back and do this analysis we actually did a whole M&M presentation, but I often wonder, what if the EMR, like if there's anything that artificial intelligence should be good for, it should be for helping us not miss these kinds of cases. And what if the EMR could have flagged that head circumference and made it one of those errors that you have to click through every time before you can sign orders or before you can move to the next thing? So anyway, so I think, Rob, to answer your question, there's a lot of room to improve EMR workflow to make it more clinically relevant for vitals and exam. Ashley Sherman says, thank you. It's a challenging issue that probably needs more investigation. This is in reference to not discounting women with chest pain. And thanks for the comment on atypical. We have Shannon's comment. I see. So Shannon is clarifying that Murphy's sign is actually for acute cholecystitis regardless of stone presence. Thank you. Sonia says, really appreciate this presentation. I too am worried about bias in the sick or not sick and wonder if it's not overcoming bias, but admitting and acknowledging them that may shift our study of this factor. Thank you for that. I think that's true. Shannon says, brilliant, ask Rob. And then Paul Costello says, I'm reminded of the recent AFP editorial about cautious use of MRI ordering in patients suffering chronic MSK joint pains. Thank you. I think that's true. Great. Well, I appreciate you all being so engaged and spending time with me this morning. Thank you so much, and hope you have a wonderful day, and please stay safe.
Thanks for watching. Hit the subscribe button for more medical content.